So the topic is a unified approach to higher risk MDS, standard and emerging therapies. So these are some of the treatment options that we have for higher risk MDS, and I put this up to serve as an outline for my talk. Someone else is addressing the role of hematopoietic cell transplantation, HCT, and I'm focusing on the data to support the use of hypomethylating therapy. A few slides about induction chemotherapy for patients with higher risk MDS, and then I have several different investigational agents where studies are currently being done. So the hypomethylating agents actually incorporate within the DNA. This is showing azacitidine intracellularly converted into decitabine. They insert within the CpG islands of the DNA, and we believe they work by inhibiting DNA methyltransferase. And when you inhibit DNA methyltransferase, you're no longer able to methylate your DNA. And the methylation of the DNA serves to silence that portion of the DNA. So any portion that is methylated is not translated or transcribed. And the theory is that what ends up happening as we age is we methylate more and more of our DNA, and some of the areas that are methylated are actually tumor suppressor genes. So if you can reactivate this portion of the DNA, you can restore cellular apoptosis and lead to death of some of the cancer cells. So the AZA-001 trial is the pivotal phase 3 trial that led to the approval. Well, actually, there's another study that led to the approval. Let's just say it's the first study to show a survival benefit in MDS patients. It does have an interesting design, which some people criticize it for, but I actually think it's a strength of the study. And that is that when the patients presented, they were randomized to either receive VIDAZA or what the physician thought was best. And the physician was given 3 choices: best supportive care, low-dose Ara-C, or induction chemotherapy. So the physician would choose one of those 3 choices, and then the patient would subsequently be randomized to the physician's choice or VIDAZA therapy. And you can see that for the majority of patients with higher risk MDS, the choice that the physician made was best supportive care. It shouldn't be surprising to you that there is an age differential in what the physician thought was best. So the people that were selected to get induction chemo tended to be younger, they tended to have more aggressive disease, and the people who were selected to get the best supportive care tended to be older and have less aggressive disease in regards to their bone marrow blast count. The trial was designed to answer the question overall, what's better, VIDAZA versus conventional care regimens? And so you're going to see that it's pretty well balanced between the VIDAZA and conventional care regimen arms. But then if you start going into the subgroups, you do see some imbalance there. And so you can see that there were more patients who had AML. This study allowed up to RAVE-T, the old classification, so up to 30% blasts. And then with best supportive care, there were less AML patients. And then when you look at the age was a little bit younger in the induction chemo patients. So this is what the survival curves actually look like. Whenever I discuss this with my patients, you talk to them, which curve do you want to be on? The answer is neither, please. So we do talk about how azacitidine has been shown to improve overall survival, and that's very true. But, this is not exactly a curve that you would show to a patient and be extremely happy about. The difference in the median overall survival was around 9 months. But most of the patients with VIDAZA did end up progressing, as well as on the conventional care arm, and dying from their disease. This is looking at hematologic improvement. So as Guillermo mentioned, azacitidine and other hypomethylating therapy are used for lower risk MDS because they can also improve blood counts. And so if you look at the azacitidine arm, about 49% of the patients had some degree of hematologic improvement. And then this is breaking it down into the different subgroups, erythroid, platelets, and neutrophils, comparing it to the conventional care regimens. So these are some of the adverse events that were experienced. The principal adverse events were cytopenias, which is not surprising. They did look at infectious risk, and they looked at hospital days with IV antibiotics, and it was less in the azacitidine arm than it was in the conventional care regimen arm. This is a comparison to best supportive care only. There have been attempts to try to define who might be more likely to have a prolonged and good response to azacitidine therapy. This in the A was the training cohort, and in B is the validation cohort. The validation cohort came from the AZA 001 trial, and this training cohort came from the French MDS group, patients that they had treated. And so they found that the ECOG performance score, the presence of peripheral blast, red cell transfusion dependence, intermediate risk cytogenetics, and poor risk cytogenetics all played a role in whether patients responded and what depth and degree of response they had to the azacitidine therapy. So you could add these numbers up. They were all 1 except for poor risk cytogenetics, and they would be placed into low, intermediate, or high risk. And you can see that the low risk patients had a better response to the azacitidine. And I don't think any of us finds this very surprising. But I do think this is useful when talking to patients and coming up with an ultimate overall plan. So what I might do is, if a patient is in the higher risk category, make a plan to proceed to allogeneic transplantation early and not wait for them to fail azacitidine therapy, because I'd be concerned that they're not going to have a very durable or prolonged response to azacitidine if they get one at all. So this is the data with decitabine. So decitabine has also been studied in a phase 3 randomized fashion to look for a survival benefit. There are some issues with this study that I think it's important to point out, and one of them is that the dosing of the decitabine was different than what most of us give. So in your clinic, if you're giving decitabine, most clinics give it over 5 days at a dose of 20 milligrams per meter squared. This dosing would actually require inpatient hospitalization because they give it over 4 hours every 8 hours for doses 1 through 3 every 6 weeks. The other issue is that if patients actually responded, as you see here, they were taken off the treatment. So they did not continue the treatment in responding patients. So these are 2 criticisms of the way that this trial was designed. And in fact, around 26% of patients were taken off of the study because of normal completion. So basically meaning that they developed a remission and they stopped the treatment because they responded. So it should therefore not be surprising that they didn't see much of a survival benefit, because we now know it's probably not a good idea to stop these drugs. So we don't stop these agents if patients have responded. If they develop a remission, you should continue them on the treatment. The median overall survival was 10.1 months in the decitabine arm, and it was 8.5 months in the supportive care arm, and this was not statistically significantly different. So no survival advantage for decitabine. Is it because it's truly different, or is it because of the trial design errors that I pointed out? Well, I don't have the power to answer that question, I'm sorry to say, but people certainly have their opinions about it. And yes, it could be due to the number of treatments. It could be a different population. It could be how the drug was given, or it could be that there actually is a true difference between azacitidine and decitabine. There have been no direct comparisons head-to-head of azacitidine and decitabine as far as I am aware. Induction chemo. So there actually have been very few trials that have compared how AML patients do with induction chemotherapy versus MDS patients. And this is one study from Guillermo's colleague, Dr. Este, and now my colleague, Dr. Este, where patients were treated with induction chemotherapy with a diagnosis of MDS or AML. Now, this is using the old FAB classification, so you have RABE-T in there, 20 to 30%, and then the AML patients, and you see the numbers here. The patients with RAEB actually ended up doing worse than the frank AML patients, but they were also more likely to have poor prognostic characteristics, and they were more likely to have complex cytogenetics. We have learned a lot about AML and how it can be different when it evolves out of MDS versus being de novo. And so, as Amy mentioned and Guillermo mentioned, there's been a lot of work looking at molecular characteristics of diseases. And we now know that AML that comes out of MDS is more, does have a different underlying mutational pattern than patients who present with de novo AML. So these MDS patients that are higher risk probably not only have more complex cytogenetics, but also likely have different underlying mutational profiles that could lead to impaired responses to induction chemotherapy. So Guillermo's going to discuss this in the next talk, but it is a big problem in MDS, and that is what you should do for these patients who fail azacitidine. So I know there's a question on how long high-risk MDS patients live after they fail azacitidine, and it's not good. So pick the lowest number on that question. This was not a randomized trial. This was a retrospective analysis of how patients did after failing azacitidine therapy. And I could like to convince you that the transplant patients did the best, but there's obviously a huge selection bias present in this analysis. So the patients who ultimately went on to go and receive their transplant were probably younger and probably had a better performance status. But then if you look at these other treatments, they're not working so well. So I told Guillermo I'm very interested to see what he's going to recommend for these patients. But if they are a transplant candidate, that should definitely be considered. So I'm moving on now into some of the trials that have been done. And there have been a lot of studies looking at how can we improve on azacitidine therapy. And this is one such study. It was a randomized phase 2 trial. So you can have randomized phase 2 trials. Just remember that the power to detect a difference may be less with phase 2 trials, and also the goal of phase 2 trials is not necessarily to show a significant difference in outcomes in comparison to a randomized phase 3. But this is a randomized phase 2 trial, and they treated patients with azacitidine alone, or they treated patients with azacitidine plus entinostat, which is a histone deacetylase inhibitor, with the idea that you can improve the outcomes with azacitidine therapy. But unfortunately, there wasn't any difference between the two groups. It included both MDS, CMML, and AML patients who came out of prior MDS, and you can see that if anything, the azacitidine arm did better than the combination arm. One of the problems that you can have when you start doing these types of combination therapies is that there's increased toxicity and less compliance. And so there are some people who criticize these types of studies and say that it's giving azacitidine the way it should be given versus giving azacitidine very rarely. So, that could be a criticism, but I think the point is that if the combination therapy is too toxic to give, then it's probably not going to work. This is a study that looked at azacitidine plus lenalidomide, published in Lancet Hematology, and basically they gave the azacitidine at 75 milligrams per meter squared days 1 through 5, and the lenalidomide 25 milligrams on days 6 through 11. And there's some interest in combining these two therapies and potentially improving outcomes in MDS patients. Subsequent to that, a phase 2 randomized trial done through the cooperative groups randomized patients to receive azacitidine alone, or azacitidine in combination with lenalidomide, or azacitidine in combination with vorinostat. Now, I showed you this previous slide because one of the criticisms that people have about this SWOG trial is maybe they didn't get the combination of the therapy right. And, that is one potential issue, but what I can tell you is that at least in this study, there was no difference in these three arms. The last data set that I saw showed no difference. So despite our attempts so far, we have not yet been able to improve on the results with azacitidine alone. This is a study that looked at higher risk MDS after they had failed azacitidine. It's with a drug called regisertib, which is a PLK and PI3K inhibitor. And there was a lot of excitement about this, and everyone was hoping it would be successful, but unfortunately it failed to meet its primary endpoint. This drug is not, it's still being investigated for a subset of these patients who have failed azacitidine to see if perhaps patients who have a primary failure would do better. So there is an ongoing trial investigating this agent, regisertib. Birinapant, there's a lot of excitement about this drug as well. The trial itself was called the BLAST trial, so anytime you have a name with a BLAST trial, everybody gets really excited about that. I think the mechanism of action is pretty cool because it's a SMAC inhibitor, which, I think we all need every once in a while. You might want to do that to me if I stay up here much longer. But this trial, unfortunately, also showed no improvement. So this was another phase 2 randomized trial where patients were treated with azacitidine versus azacitidine plus birinapant, but they did not meet their endpoint of improvement with the azacitidine plus birinapant arm. And this is the summary of the study, but it was a phase 2 randomized double-blind placebo-controlled study. And again, adding things to azacitidine didn't make it better. Decitabine. So Guillermo's done a lot of work with this agent, but it is also known as S110. And what they have done with this, is they added guanosine to the decitabine. So here's the decitabine that you see here. And they added guanosine. And what the guanosine does is it inhibits cytidine deaminase. So there's a more prolonged exposure to the agent. And so the theory is that you soak up more of the hypomethylating more of the demethylation, and that it leads to more demethylation because you inhibit the enzyme more, and so you have a better response. And this drug has shown some impressive responses in patients who have failed hypomethylating therapy. And right now there is an ongoing trial looking at MDS or CMML patients who have failed prior hypomethylating therapy. And they're being randomized to either get the decitabine or a treatment choice of low-dose Ara-C, induction chemo, or best supportive care. And this study is ongoing. Atezolizumab, so I can say that one, that's pretty good. But it's an antibody, it's directed to PD-L1, and this drug is approved for bladder cancer. And it basically turns on your immune system, the patient's immune system, to help recognize the cancer cell more easily. And so this is an antibody to PD-L1, and it prevents deactivation of the T cells, and so the T cells stay more active. And there is a trial combining atezolizumab with azacitidine to see if we can improve responses, and this trial is ongoing now and enrolling patients. There are actually several different cohorts to this trial. The first cohort here was for patients who had relapsed or refractory to hypomethylating therapy, but the subsequent cohorts will be newly diagnosed MDS patients, treating them with the alatizumab plus azacitidine. The primary endpoint is overall response rate by IWG criteria. A few words about transplant. So another speaker is going to address transplant for MDS, but one of the things that we have to think about is when is the appropriate time to do it. And as Guillermo pointed out, for patients with low-risk disease, there hasn't been a proven survival benefit for transplantation. And most of the studies that have, actually all of the studies that have looked at when it's appropriate to transplant someone are retrospective studies. There's been no randomized trial addressing the role of transplantation for MDS patients. But this study was a retrospective study looking at how patients do, whether they have early stage MDS, low intermediate 1, or more advanced MDS with higher intermediate 2. And it showed that if you delay transplantation for patients with high risk MDS or intermediate 2 risk MDS, that they have a worse survival. So they have a loss of life expectancy. So these patients are patients who should be considered for transplant earlier on if they're eligible. So it's a retrospective comparison. It only looked at primary MDS. It only had marrow grafts in it. It only had HLA identical donors and only used high-dose intensity conditioning. Guillermo showed this slide earlier. This is looking at reduced intensity conditioning for MDS patients over the age of 60. And that basically with lower intermediate 1 risk disease, patients with early stage MDS should not be going towards transplantation because there was better outcomes seen with non-transplant therapy. So this transplant arm that you see here in blue came from the CIBMTR, the Fred Hutch and the Dana-Farber, and the non-transplant arm came from the Nordic group, the French MDS group, and the MRAW database and PAVIA database, basically showing that these patients did better if they did not go to transplant. Now, for intermediate 2 and high risk, this is looking at just reduced intensity conditioning. There was some patients who had a better survival. I think that this goes back to which one of these curves do you want to be on? Probably neither would be the answer. But there are some patients who can have a prolonged survival with transplantation. This whole idea of preparing people for transplant, what's the best way to do that? The answer is we don't know. Should you give patients some type of induction chemotherapy, or should you give hypomethylating therapy before transplant? We don't know. And should it even be used at all? We don't know the answer to that either. This is one retrospective study that showed untreated patients, so these are MDS patients, and patients who received induction chemotherapy, there was no difference in their overall survival following a stem cell transplant. This is a retrospective analysis, and they adjusted for a lot of different factors. The benefit of azacitidine is that it has a lower toxicity profile, less infectious risk given outpatient, and there may be some post-transplant effects as well, which could improve outcomes. So we do have a trial right now that's randomizing patients to receive either azacitidine or induction chemotherapy, followed by allogeneic transplantation. This is my summary slide. I was just involved in an abstract with a large group of people, and one of the things that was most shocking to me about the abstract is that the majority of MDS patients are actually not treated. So, we sit up here and we quibble about azacitidine versus decitabine, how we're going to improve the rates with azacitidine. And, the fact of the matter is we could probably do the most benefit about educating physicians about how MDS patients could be treated. And I think that there's a lot of ageism that occurs in our treatment of patients. And, there's this thought out there, if you're over age 70, you've got low blood counts, just let it go. But about 60% of MDS patients in this database were not treated. So that's pretty alarming to me. And then of patients who are treated, the most common treatment that they get is growth factor therapy, even though it's not FDA approved. And then if they do get hypomethylating therapy, it's a very small proportion of them that are actually treated with this. So I think that, we've talked about all of these studies, but probably the biggest issue is education about treatment of patients and how we should be more aggressive in diagnostic workup. And with that, I'll end, and thank you for inviting me to speak.